I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm delighted to have with me Professor Pieske, the Chair of Cardiology from Charité University Medicine Berlin and the German Heart Center Berlin, who is Principal Investigator of the Parallax trial that received a great amount of attention at this ESC. Welcome, Professor Pieske.
Thank you very much, Harriette. Welcome to you too.
Thank you. So you led a clinical trial that tested the efficacy of sacubitril/valsartan among patients with symptomatic heart failure and an LV ejection fraction greater than 40%. And you presented the hotline results in the last couple of days. Why don't you go over some of the methodologic aspects of your trial and choice of outcomes, and let us know how you split the alpha for the primary outcomes. I think that's a matter of great interest to researchers.
So thank you for the opportunity. I mean, you already mentioned that we looked into patients with heart failure and the mid-range or a preserved ejection fraction. And as we all know, this is a substantial subset of all heart failure patients, accounting for more than half of heart failure patients. And you also know that we do not have specific guideline recommended therapies for these patients. So this is a big unmet clinical need, the specific management of these patients. In the guidelines, we read that it is a class 1 recommendation to control comorbidities and risk factors, such as diabetes, hypertension, overweight, and others, and to use typically loop diuretics for symptom control, but we have nothing specific. In our daily practice, many of these patients are on a RAS inhibitor for their comorbidities, hypertension, diabetes, renal insufficiency. But there is no specific indication for a RAS inhibitor in heart failure with mid-range or preserved ejection fraction. So what we tested was the effects of the angiotensin receptor neprilysin inhibitor, sacubitril/valsartan, in patients with heart failure with mid-range or preserved ejection fraction. And we stratified these patients according to their individual background therapy for comorbidities. So at randomization, we had identified 3 strata of patients. One stratum where patients were on an ACE inhibitor as their individual background therapy for their comorbidities. A second stratum where patients were on an angiotensin receptor blocker for their comorbidities. And a third stratum where they had no RAS inhibitor at all. There were neither an ACE inhibitor nor an angiotensin receptor antagonist. And then we randomized these patients, sacubitril/valsartan versus enalapril in the ACE inhibitor therapy stratum, sacubitril/valsartan versus valsartan in the ARB pretreatment stratum, and sacubitril/valsartan versus placebo in the RAS naive patients before recruitment into the study. We followed these patients for 6 months, 24 weeks. And this was the overall concept of the study, to look into the different comparators that had not been done before. The primary readout was a composite of change in NT-proBNP, sacubitril/valsartan versus comparator over time. And a co-primary was a change in 6-minute walk distance over time. Key secondary readouts were change in quality of life, assessed as KCCQ, clinical summary score, and neuronic heart association class. And we also looked carefully into tolerability and safety, and I will come back to this in a second. So this was the key concept of the study.
Right. I thought that your choice of comparator groups addressed some of the criticisms that Paragon had received, and also moving the threshold to 40% from 45% took care of that range that had not been included in a trial population before. So kudos to you for those design elements.
Thanks.
Tell us about the alpha distribution and the primary outcomes and what your main findings were.
So we had a hierarchical statistical analysis plan. The alpha was split 90 and 10% BNP and 6-minute walk distance. And then there was a hierarchical assessment for the secondary outcomes. And our key findings were as follows. First, we did observe a significant reduction in NT-proBNP with sacubitril/valsartan as compared to the individual comparators. There was no difference between the three strata. So irrespective of whether the patient was compared to an ACE inhibitor, to an ARB, or to placebo, there was also a comparable significant reduction in NT-proBNP with sacubitril/valsartan versus the comparator. That reduction in NT-proBNP became evident and significant after only 4 weeks of therapy. The key statistical assessment was after 12 weeks. There it also was significant, the difference, and significance was maintained until week 24. So we met this first component of the primary endpoint, and please remember NT-proBNP is a surrogate marker for disease severity and prognosis. The secondary component, 6-minute walk distance, there was in both arms a slight increase in 6-minute walk distance over 24 weeks by roughly 10 meters. And there was no significant difference between sacubitril/valsartan and the comparators. So overall, slight improvement in our patient population, 10 meters, that is less than the 30 meters that we deem clinically relevant as a change, but no additional benefit with sacubitril/valsartan.
Right, so not a significant difference compared to the comparator group.
Exactly, right.
Why do you think the improvement in NT-proBNP afforded by the intervention had an attenuated effect with time?
Well, I mean, so if you look into the curves, you see that the largest benefit was after 4 weeks, and then the difference between the comparator and sacubitril/valsartan and NT-proBNP became smaller, but it was there over all the time. So whether there is a biological explanation or whether this is an observation that where the absolute change is not the key aspect, I cannot answer the question. I mean, what we know from the early phase 2 study Paramount is there we also found a quite early reduction in NT-proBNP levels. And we, of course, discussed the underlying mechanisms, and they could be several folds. They could be related both to a natriuretic effect of the neprilysin inhibitor component, which may be most prominent early in the course of the trial.
Right, and abates with
and
time.
an additional reverse remodeling or anti-adverse remodeling effect, which may be more prominent over extended observation periods. So I think these two components should be considered.
Please tell us the effects of the intervention on your secondary outcomes.
So the key secondary readout, which is of course also of relevance to our patients, was quality of life, KCCQ clinical summary score. We did observe overall a relevant increase in KCCQ clinical summary score by roughly 10 to 12 points in both arms. There was an early significant benefit with sacubitril valsartan over comparator after 4 weeks, which then gradually faded away over time. And after 24 weeks, this difference was no longer significant. It is important to note that patients in general did improve, and 10 to 12 points, this is quite a lot. That is substantial. And here it is also important to note that we had, and this is also unique in Parallax, we said we only want to recruit patients into Parallax who have clearly impaired KCCQ scores, so the threshold was below 75. The higher the better, so below 75, and this means we have only recruited patients into Parallax with clearly impaired KCCQ scores, and they overall then tended to improve and early benefit, later on no significant difference. Similar with New York Heart Association class, which was also key secondary, there was in 1/4 of patients New York Heart Association class improved. In 3/4 it didn't change, and a small subset it worsened. And there was again no difference after 24 weeks between the two arms.
Right, so in the pre-specified secondary endpoints at the pre-specified time points, there was no statistically significant difference between the groups.
Correct.
That we discussed. What is your observation that as LVEF increases, we become less clear about the pathophysiology of heart failure? That among those with heart failure with preserved EF, there are heterogeneous conditions that account for the disease, and that RAS inhibition may not be effective in the group as a whole.
I think this is a crucial question, and let me try to give an answer. So in heart failure with reduced ejection fraction, and by guidelines, we define this currently below 40 or 40 and less. We typically have a dilated left ventricle. We have increased wall stress. And this is the key signal for the activation of the renin-angiotensin system and the sympathetic nervous system in concert with low cardiac output and so on. And according to Laplace, the larger the ventricle gets, the thinner the walls get, the higher is the wall stress, and that is signals for release of natriuretic peptides, and it also is implicated in the activation of the renin-angiotensin system. In heart failure with preserved ejection fraction, you have exactly the opposite. You have a small ventricle. The patients typically have thick walls, hypertrophied walls. The diameter of the left ventricle is small, and according to Laplace, wall stress is not increased. So the overactivity of the renin-angiotensin and the sympathetic nervous system is much less in heart failure with preserved as compared to reduced ejection fraction. And MREF is somehow in between. This is point one. And if a system is not overactivated and you inhibit it, then maybe the benefit is not that big. So this is one part of the explanation. Another part of the explanation could be that In heart failure with reduced ejection fraction, the larger the ventricle gets, the higher sympathetic overactivity, the more is the pathophysiology that underlies heart failure at that stage, independent from the early etiology, be it ischemic, be it inflammatory, be it dilated, so that in these end stage hearts, that may no longer matter, and you have other therapies that are not etiology specific for these patients. Again, in HFpEF, that may be not the case, and it may be a big difference if you have, for example, TTR amyloidosis underlying heart failure with preserved ejection fraction versus severe hypertensive heart disease, for example, or genetic cardiomyopathy. So I strongly believe we have to better stratify our HFpEF patients, because in HFpEF, the etiology and the underlying pathophysiology may much more be important for assigning directed therapies to these patients. So stratification of patients, I think, is more important here. And then, and this is the last part of my answer to your difficult, albeit important question, is where does HFpEF end and where does HFrEF start? Is there something in between? Are these two complete different disease entities, or is this a continuum? And my clinical observation and my scientific concept is that HFrEF starts once intrinsic contractility of the left ventricle goes down, ejection fraction slightly decreases, the ventricle starts to get bigger. We are in the early MREF range here, and then there is a continuum, and I think the more ejection fraction goes down and the left ventricle dilates, the more effective are RAS inhibitors or sacubitril valsartan. And in the subset of true HFpEF patients, so ejection fraction 60 and higher, small ventricle, no sign of dilatation, I think this is a distinct entity. And here, truly, our therapies so far do not really work well.
Beautifully said. I think that your deep and clear thinking on the subject shines through. So thank you for sharing your thoughts with us. My last question, do you think that we need to retire our efforts of testing these neurohormonal therapies in patients with HFpEF? Has the time come for us to get greater clarity on the pathophysiology in HFpEF before we subject patients to further testing with this class of agents?
I mean, this is again a very, very good and important question. I would like to give two parts to the answer very briefly. First, we had an interesting safety signal in Parallax, and we looked into adverse events, severe adverse events related to heart failure hospitalizations or heart failure related cardiovascular death. This was a post hoc analysis. This was SAE reports. They were non-adjudicated. But we saw, and this corroborates finding from Paragon HF, a 50% reduction in SAE events related to heart failure hospitalizations in our MREF and PEF Parallax patients. So this was a very good safety signal and corroborating the outcome benefit signal from Paragon. And in Paragon, it became evident that patients below the median of left ventricular ejection fraction, so below 57%, did benefit, and above the median, the benefit was no longer there. That was complicated by the fact that women somehow benefited more than men and already at higher ejection fractions, obviously. And now we are in the discussion, is there a normal ejection fraction, which can we have a global value as a normal ejection fraction? Are there sex differences? Do women have a higher normal ejection fraction? And when they go down from 65 to 60, for them that's already reduced. And men have somehow lower normal ejection fraction. So if a man is 60, that's perfectly normal, and 55 is then abnormal. So this is a little bit the scientific discussion where we are at the moment. So what is a normal and an early reduced ejection fraction? Do we have different cutoffs here? And this is, of course, important to your question. Should we at the moment stop to test RAS inhibitors in true HFpEF, because we do not really understand the pathophysiology of the disease? And my answer here is maybe I would like to see SGLT2 inhibitor data, outcome data, for example, where we have a more global metabolic maybe intervention that may be beneficial in both types of heart failure. I don't know. I would say this is not a RAS inhibitor, so it's another type of intervention. So if it is about two RAS inhibitors, maybe the answer would be yes at the moment. If it is about other therapies, I would say I would be confident that there may still be something that fits for more than only a subset of HFpEF or MRF patients.
I agree with you, and I too hold out on SGLT2 inhibitors as potentially providing benefit to patients with HFpEF based on results from previous trials and the kinds of patients that have demonstrated response to SGLT2 inhibition. I'm going to thank you very much for your time this morning. It was such an honor for me to talk to you and for our viewers to learn from you. Congratulations on a trial that was very well thought out, very clever in its analytic plan, and that was conducted with impeccable rigor. I wish you well. I hope our paths connect again. Thank you so much.
Thank you. Thank you very much.